Medurstand, Understanding Medicine.
I'm Professor Aziz-ur Rehman from Medurstand-Understanding Medicine. And today we are going to talk about a new medication, Resmetirom. It's a new treatment option for metabolically active steatohepatitis called MASH. I'm really excited about this new development because MASH is extremely common and there were no treatment options, no FDA approved or EMA approved or scientifically proven medical therapies. So since it is a common disease and there were no treatments and now there is one, I think it is worth talking about it. So a little bit of background. NAFLD and MAFLD, these are two abbreviations of terms called non-alcoholic fatty liver disease, and currently it is called metabolically associated fatty liver disease. Now the concept is the commonest cause of fatty liver disease was alcohol consumption, excessive alcohol consumption. And when people developed the same pattern of fatty liver, but there was no history of excessive alcohol intake, it used to be called non-alcoholic fatty liver disease. Implying that since it is not alcohol associated, it is due to some metabolic derangement. So that was kind of inference. But now since we know that this is actually metabolically associated fatty liver disease, so to make it more direct, so we call it metabolically associated fatty liver disease. Anybody who has this fatty liver and with more advanced stages, but does not have history of significant alcohol intake. Little bit of alcohol intake would not make it alcoholic fatty liver. So that could still go with this metabolically affected fatty liver disease. And same stage, and this is just accumulation of fat in the liver, which we can see with ultrasound. But if the same progresses to the next stage, there may be actually inflammation in the liver, and that would result in hepatocellular injury and regeneration, and this is manifested as elevated ALT. Of course, if there is elevated ALT, that would indicate hepatocellular injury, but formal diagnosis of NASH is made on biopsy. So on biopsy, you have to demonstrate that there is actual inflammation. Now, biopsy has got its limitations, so we're looking for something which could tell us about NASH without doing the biopsy. So I think we go by ALT and also by a test called FibroScan. So if somebody has fatty liver but ALT is significantly elevated, maybe 3 times upon normal, and there is no other obvious cause of elevated ALT, then we attribute it to fatty liver disease and we label it as NASH. Or now we will call it MASH, metabolically associated fatty steatohepatitis. So this is potentially serious because there is inflammation, and inflammation means it is going to be followed by further stages and ultimately liver failure or hepatocellular carcinoma. So this is the natural host. Benign accumulation of fat in the liver, which we detect only on ultrasound. Patients are mostly asymptomatic, only on ultrasound, or maybe on report blood testing, little bit of elevated ALT, but it can go on to develop MASH, which is inflammation, necrosis, followed by fibrosis. This is of course a very gradual process and mostly irreversible. Why irreversible? Because the background cause is usually not addressed. The background cause is progressive weight gain. So as long as weight gain continues, this will keep progressing to the next stage, fibrosis. Then fibrosis itself has got 4 stages, and ultimately it will become cirrhosis, which is irreversible disease. Now cirrhosis again will go through different stages, and ultimate would be liver failure, and patient would develop decompensated chronic liver disease and ultimately may die of one of the complications, or some patient may develop hepatocellular carcinoma. Although the disease process, the disease progression is slow, but ultimate is very, very horrible. So if there's anything we can do, we must try. So pathogenesis and the treatment is primarily excess energy intake, which results into weight gain. So those who have visceral obesity, they are very likely to have fatty liver. So this is the cause, and I think rational treatment would be to reverse the disease process by losing weight. To lose weight, you have to do both at the same time. You have to cut down your calorie intake very, very significantly, up to 50%, and you also need to do physical activity regularly. The contribution of fat loss may be 80%, and the contribution of dietary restriction may be 80%, and the contribution of exercise is only 20%. Of course, exercise has got other benefits, but you cannot lose weight unless you do caloric restriction. So this treatment was obviously available to us and is still available, but most people are unable to do it. I'm not saying that the importance of weight loss is now less because we have this Resmetirom available. Weight loss is still very, very important and perhaps the primary treatment, but at least we have one additional tool for those who are unable to lose weight in a stipulated time. The previous treatment used to be vitamin E, being an antioxidant. This used to be prescribed, and silymarin containing herbal treatments. These were available and we used to prescribe, but these have got very, very limited efficacy and in some cases unproven. And many patients would end up having liver failure and they would require liver transplant. Previously, the commonest indication for liver transplant was hepatitis C or hepatitis B related liver disease. But now we have very effective treatment for hepatitis C. So these days, fatty liver or MASH or NASH is becoming the leading cause indication for liver transplantation. In the USA, it has already become #1 indication. In Pakistan, it is also becoming the fastest growing disease. So this lecture is based on the study. This is the study which actually led to the approval of this new drug, Resmetirom, for the treatment of MASH with fibrosis, and this is the Maestro-NASH study. And these are the two QR codes. If you are interested in the original article, you can scan this one and it will lead to the original article which is published in New England Journal of Medicine. And this is the summary by a society, and they have given the summary. I think you can go to the summary slide also. So the study design was the key question for this study was, does Resmetirom decrease fibrosis and produce a resolution of metabolic dysfunction associated steatohepatitis MASH with fibrosis? So that was the study question, and this was addressed in a very, very nice way. To understand this study, you I think need to understand what is this Resmetirom. Resmetirom is a new drug. It is actually thyroid hormone receptor beta selective agonist. So, you know, thyroxine has a receptor in all body cells, including the liver cells. And the liver cells have a sub variety of the receptors called beta. So, in liver, this thyroid hormone, it promotes beta fatty acid oxidation in the liver, reducing fat contents. So that is what is the culprit. So fat contents are reduced with use of Resmetirom, and the activation of TRH-beta reduces levels of intrahepatic triglyceride. So once triglyceride level is reduced, fatty liver will also be reduced, and then further progression to fibrosis and cirrhosis will also be reduced. Now, you would imagine that these thyroxine, if thyroxine related substance is given to somebody who does not have hypothyroidism, may cause hyperthyroidism. Actually, that may occur in some very small percentage of people, but this is actually function independent of the other thyroid functions. The thyroxine has got, this is a very selective action on the liver cells through this subtype of receptor called beta. So why is this important? MASH, formerly known as non-alcoholic steatohepatitis, abbreviated as NASH, is highly prevalent and affects 30% of people worldwide. Now 30% means every third person. That makes it one of the most prevalent diseases. And MASH is the fastest rising cause of hepatocellular carcinoma and cirrhosis, and is an indication for liver transplant in the USA. And in other countries like in Pakistan, it is also becoming one of the indications. And up to 25% of patients with MASH will develop cirrhosis. So MASH is present in 30% of people, and 25% out of them will go on to develop some degree of cirrhosis, with fibrosis stage being the most important predictor of all-cause mortality, liver-related events, and cardiovascular disease and metabolic dysfunction associated steatotic liver disease. Why this fatty liver is associated with all-cause mortality? Because it also predicts increased cardiovascular mortality and increased stroke and other causes responsible for death. And Resmetirom is the first drug to achieve both fibrosis improvement and MASH resolution in phase 3. So there are two criteria. One is the fibrosis improvement, which can be done by fibroscan, or the other is MASH resolution, which can only be determined by liver biopsy. So we can actually do both. If any one of them improves, we can feel reassured that the medicine is working. So in this study, the design was that 52-week multi-center double-blind randomized placebo-controlled phase 3 trial, and the settings 245 centers in 15 countries, conducted between March 2019 and July 2021. There were 955 patients with metabolic syndrome and biopsy-proven MASH. Now this is the catch point. It was biopsy-proven MASH having non-alcoholic fatty liver disease activity score of more than 4. This score can be determined only on biopsy. Or the fibrosis score, which can be determined by biopsy as well as by fibroscan stages from fibrosis from F1, there is F0, that means no fibrosis, or F1A or FB. F1A is minimal, FB is significant, F1B, and then F2, F3, and F4 is frank cirrhosis. So the patient included in this study were F1B to F3. So interventions were participants randomized into 1:1:1 ratio to either Resmetirom 80 mg or Resmetirom 100 mg or placebo. This of course was above the standard care like lifestyle changer. Stratification for presence of type 2 diabetes mellitus and fibrosis was done, and those who had fibrosis of F1, F2 and F3, they were selected for intervention. All participants received nutrition and exercise counseling according to current recommendation. As I said, the primary treatment of fatty liver disease is still weight reduction, and these people, they received counseling for weight reduction management. So everyone received this counseling, but some were given Resmetirom 80 mg, others were given 100 mg, and still others were given placebo. And a second liver biopsy was performed at stage 52. Outcome and definitions. a dual primary endpoint assessed at week 52. And dual endpoints I'm going to explain one by one. The first one was MASH resolution, whether or not their metabolically associated steatohepatitis resolved based on biopsy. And these are some of the features used in biopsy. I think pathologists understand it better, but as an internist, you just, I think, note down that NASH score, if it was reduced then by 2 points with no worsening of fibrosis, this was considered as a positive point. That means the resmetirom was effective in reducing NASH. And the other parameter which was studied was improvement in fibrosis by at least one stage. So stage 2 has gone back to stage 1, or stage 3 has gone back to stage 2. So that would mean there is significant improvement, and there was a condition that if there is an improvement in fibrosis score, there should be no worsening of NASH. So the requirement was either improvement in non-alcoholic steatosis score on biopsy or fibrosis score on FibroScan without worsening of the other. So the results: 955 patients randomized, mean age 56.6 year, mean body mass index of 35.7. That means all were obese and majority were white. Most had metabolic risk factors like diabetes, hyperlipidemia, hypertension. Most patients had F3 fibrosis. So majority, the 60% of those who were included, they had advanced fibrosis F3, and 33% had F2 fibrosis, and only 5% had F1B fibrosis. So F1 or less were not included. And for MASH resolution with no worsening fibrosis, resmetirom 80 mg and 100 mg was superior to placebo. Now this is interesting. We had already defined two criteria. One is the MASH resolution, the other was fibrosis score reduction. So for MASH resolution, there was significant improvement. Those who received 80 mg, they had 25.9% improvement, and those who were given 100 mg of resmetirom, there was 29.9% improvement. And there was 9% improvement in placebo group also, because they were also following certain lifestyle changes. So there is no doubt that resmetirom in both doses tested, 80 mg or 100 mg, was effective. Look at the p-value, and the results were highly significant. So for decrease in fibrosis score by more than 1% with no worsening of NASH score, this was the second criteria. Resmetirom 80 mg and 100 mg were superior to placebo, 24.2% and 25% versus 14.2%. So again, people who were on placebo, they also had some improvement, but the improvement in people who were on resmetirom was significantly more than the placebo, with a p-value of less than 0.001. So I think this study clearly demonstrates that resmetirom in both the doses, 80 mg and 100 mg, is effective in reducing fatty change and also in reducing fibrosis. So results again, I think in graphical form, this is the NASH resolution with no worsening of fibrosis, 25.9% in 80 mg, 29.9% in 100 mg, and primary endpoint was met with very, very low p-value. And this is fibrosis score, and 24.2%, 25.9% with p-value of less than 0.001. So both values, they improved. Interestingly, the secondary endpoint was LDL reduction. Since this there is a reduction, there is a stimulation of beta cell, there is stimulation of beta oxidation of fats. There was, I think it is plausible to understand that there would be some effect in the plasma lipids. So resmetirom 80 mg, 100 mg, it reduces the LDL levels also. So at one additional feature is by 13%, 60%. So one additional benefit is reduction in serum LDL level. You know, LDL is extremely important. So we assume that with this medication, we have benefits in fatty liver, in NASH, but there would be some improvement in cardiovascular and brain-related mortality and all-cause mortality because there is significant reduction in LDL. But the adverse effects were very few. You know, all medicines have some adverse effect. The effect was very, very mild, mostly gut-related, mostly temporary, and mostly self-vomiting. Diarrhea was seen in some patients, and nausea, vomiting, and very, very self-limiting. So I think these were the side effects. The key study findings: Resmetirom, both 80 mg and 100 mg dose, was superior to placebo regarding both histological primary endpoint, improvement in MASLD, activity score, and fibrosis state. And changes in lipid profile, liver biochemistries, and non-invasive steatosis and fibrosis assessment all favored Resmetirom. So study limitation, all studies have some limitation. Just to point out some of them, primary limitation of the Maestro-NASH study is the lack of data about impact of resmetirom on clinically important endpoints, including progression to cirrhosis. So of course, cirrhosis takes long time to develop. So this relatively short study did not tell us if this improvement in fibrosis score and the improvement in steatohepatitis score, if that actually reduces cirrhosis. That we did not know. Hepatic decompensation, again, this is very, very advanced manifestation, so that we do not know, but we do hope that with improvement in NASH, these would be reduced. And hepatic encephalopathy, ascites, bleeding, esophageal varices, and need for liver transplantation, we do not know. Because the patients included, they did not have frankly established cirrhosis. So that is why we do not have answer to these questions in this study. The Maestro-NASH study is ongoing and will continue for a total of 54 months, 4.5 years, to assess clinically important endpoints, and hopefully with the time we'll find the answer to some of these questions. And unclear whether patient with cirrhosis or patient with MASH and non-alcoholic fatty liver may benefit from Resmetirom. How should we apply this to our practice? So counsel patient, those patients who have this NASH or MASH, counsel them for lifestyle modification, for healthy weight loss, because that is very, very important. Consider pharmacological therapies also to help them lose weight, and advise them on regular advice. Even surgeries can be considered. We know that bariatric surgery has got very good effect on NASH. So according to the recommendation, you must emphasize weight loss and optimize cardiac risk factor by giving them statins if needed, treating their blood pressure if needed, and other stuff. But identify the subset of patient most likely to benefit from Resmetirom based on their LFTs. Suppose their ALT is elevated 3 times or more than that, 3 times upper normal. Viral serology is negative. Abdominal ultrasound has shown marked fatty liver, and fibroscan has shown fibrosis score at least F1 or F2 to F3. So I think these are the scores. I believe that if this drug is safe, I believe even in those patients, this is my impression, this is not scientifically validated yet. So those patients who have fatty liver, but they have not yet developed NASH or MASH, I believe they should also be considered on basis of experience. Start medication, dosage selected according to the weight and comorbidities and co-medication, because there is some drug interaction, and that is next slide I'm going to show you the drug interaction. In those conditions, the dosage has to be reduced. It could interfere with statins. So if somebody is taking statin, you would probably consider reducing the dose, and you would keep a closer eye on liver injury. You would keep a closer eye on ALT. So if ALT keeps rising, then you would probably stop the medication or at least reduce the dosage. Clopidogrel is again can interfere, would increase the effect of resmetirom, and probably smaller dose will do the same job. Gemfibrozil is a major indicator interaction. So I think I would rather not give gemfibrozil or would not give resmetirom if somebody is taking one of these medicines. And there may be some small other drugs which may interfere, because this drug is metabolized, it works on the liver, and any drug which is metabolized in the liver, whether the drug is activated in the liver or the drug is inactivated in the liver, that could have interaction with resmetirom. So it is best to check the interaction before you prescribe, or if you're not sure, prescribe cautiously and keep a very close eye on indicators of liver injury like ALT, AST, and gamma GT. So in summary, I think lifestyle changes leading to weight loss with resmetirom should lead to reduction in NASH or MASH and fibrosis and cirrhosis and hopefully end-stage liver disease and hepatocellular carcinoma. We have evidence of regression of fibrosis, but we do not have evidence of prevention of cirrhosis and end-stage liver disease so far, because that would require long-term study. But we do hope that with this medication, the incidence of end-stage liver disease and hepatocellular carcinoma will be reduced, and the requirement for liver transplantation would also be reduced. Thank you very much for watching this video, and I really look forward to see you in my next videos. And this has been Professor Aziz-ur Rehman from Medurstand-Understanding Medicine.